Welcome everyone to a wonderful evening of knowledge and enlightenment. Today we are going to discuss on the topic that is endometriosis and PCOS in adolescent under the aegis of AMOG's Adolescent Health Committee. This webinar is brought to you by Bridging Bharat Initiative by Bharat Serums and Vaccines. To start with the program, I would like to introduce our moderator for today's evening, that is Dr. Supriya Arvari. Madam is the consultant obstetrician, gynecologist, and infertility specialist, trained for MD at KAME Hospital and Vadia Maternity Hospital and Seth GS Medical College, Mumbai, practicing at Supreme Hospital, Bhiwandi for past 20 years. She is the Joint Treasurer and Chairperson of Adolescent Health Committee of Thane Obs and Gynae Society, Chairperson of Adolescent Health Committee of AMOGS, and then past President Indian Medical Association, Bhiwandi and Bhiwandi Medical Practitioner Association. She is the founder chairperson of Indian Medical Association, Bhiwandi Women's Wing, ex co-chairperson IMA Maharashtra State Committee for PCPNDT. She is the gold medalist at DGO and FCPS exams. Dr. Anandibai Joshi Awardee for meritorious service by female doctors. Founder organizing chairperson of annual academic events, MEGA CME of IMA Bhiwandi, ex-chairperson Internal Complaints Committee, Torrent Power Limited, Bhiwandi, and her special interests are in high-risk obstetrics and educational program for adolescent girls. Welcome, madam. Over to you.
Thank you so much, and I hope I'm visible because I can only see my full screen CV. Can we go to the gallery view? Okay. Sana, yeah, thank you so much. Dear friends, I really welcome you all to this wonderful evening where we are going to discuss problems related to adolescent health. And I must apologize for the delay because our speakers and panelists, being obstetricians that we are, were stuck in some emergency or the other. So there is a slight change in schedule, and we will start off with the panel first. The speaker for today, Dr. Jaideep Tank, will join us very soon. Now I would like to request the host to please start sharing the screen as I welcome my panelists. The first panelist for the day is Dr. Girish Mane, a very dear friend, director of the Mane Hospital in Yavatmal, past president of Yavatmal OBGY Society, past chairperson, my predecessor as adolescent committee chair of AMOGS, currently the chairperson of Foxy Adolescent Health Committee, recipient of the Foxy Smriti Milan Save Baby Girl Runner-Up Award, recipient of the Best Society AMOGS Award during his presidency, recipient of Dr. Durusha Youth Trophy and Dr. Sadhna Desai Award. He is the first winner of the Foxy's Got Talent contest. He is an extremely talented singer. He has contributed several chapters to Foxy Focus and many other publications, and he has been awarded as the best chairperson for AMOGS 2018-2020. Welcome, Girish. And I must thank him. He has signed up in spite of the fact that he has a family emergency. And really, Girish, we are very indebted to you for joining in. Thank you. The next panelist on the list is again a very, very dear friend, Dr. Sandhya Saharan, my co-friend from Thana OBGY Society, currently the vice president of our society, consultant obstetrician gynecologist attached to the Cure Hospital, the Jupiter Hospital. She has special interest in endoscopy, infertility, and yoga. She has received the Young Scientist Award in 1994, recipient of the Desa Silver Jubilee Award 2001, Best Paper in International Congress in 2003 for infertility, the Bharat Jyoti and the Best Citizens Award 2007, and she has devised a normogram for labor monitoring. Welcome, Sandhya. Thanks for signing up. The next panelist again is a very dear friend, Professor and head of the unit at the Jawaharlal Nehru College. Please welcome Professor Surekha Taide, trainer, teacher, mentor, facilitator, and guide for the past 20 years, recipient of the prestigious Dr. Anand Jivne University Gold Medal and Savitribai Phule Award for her work in the community. She's a national mentor, quality improvement and Lakshya program GOI, master trainer in emergency obstetric care, critical care in OBGY, and she has several lists of organizations where she is notable. Among them is that she's the chair of the Global Women's Health Task Force, which is doing international work, the Network Towards Unity of Health USA, and founder member of Women and Health Together for the Future, South Africa. Welcome, Surekha, and thanks for joining us. And recently, she's been doing some research on COVID, and she will be soon bringing out her papers on COVID, especially, I think, the effect of COVID on doctors. Right, Surekha? May I have the next CV of Dr. Rohan Palshetkar? Nandita ma'am is to join us soon. Dr. Has madam joined in? I am not sure yet. Oh, hi. Please welcome the AMOG's president, Dr. Nandita Palshetkar, professor in OBGY, DY Patel Medical College, Navi Mumbai, teacher for specialty, super specialty, and FNB reproductive medicine, Delhi. She is practicing more than 25 years.
Yeah, it's okay. It's okay. I've come
Okay.
in just to help
Notable,
you out
notable as that she is the past president of
That's
MOGS, past president Foxy, and currently president of AMOX. So before we begin, may I welcome our chief guest with regrets for starting late because some of our panelists and speakers were busy in some obstetric emergencies. And may I request Nandita madam to please give the welcome speech and presidential address.
Oh, no, I thought you needed, I think Supriya, fantastic job. I'm very happy on behalf of Adolescent Committee of AMOGS that you're doing this. Good to see Girish, Rohan, Surekha, and Sandhya over here. I thought Sandhya was also busy with the some emergency. So please go ahead. I think it's Adolescent Week and lots of programs on adolescents being done. 1/3 of our population is adolescents, and I think we need to cater to them, especially in COVID times when access is very difficult. And you've had some wonderful panelists. I think those who have done a lot of work with adolescents, especially Girish, who is on the national forum, Foxy, and he did a lot of work when I was the Foxy president also. And Surekha is the shining new star, no, Surekha, on the horizon of academics. And Rohan, I'm very happy to see you doing a lot of work in this field, especially the young people. I think you're taking everybody together. And Sandhya, I've known for 30 years, I think, Sandhya. I've seen you, what a hardworking girl you are. And I'm happy Supriya is one of my soldiers in AMOGS who's been working very hard with AMOGS. So all the best, and I'm happy that you're doing the program, and very glad, very glad.
Thank you so much, Nandita, for those kind words. And since it is my program, it cannot proceed without a share. So the share is dedicated to youth, since this is a conference on adolescent. कि शरबते रंगीन लगता था साधा पानी भी, मतलब हम पानी भी पीते थे तो शरबत रंगीन शरबत लगता था. शरबते रंगीन लगता था साधा पानी थी, पानी भी हाय क्या चीज थी जवानी भी.
वाह वाह वाह.
May we now start the panel on PCOS. I would like to Girish, yeah, please.
I have objection on the word थी.
Okay, दिल से सब जवान है, totally agree. But if you ask our children, they won't agree that we are still jawan. In fact, I get it all the time. आई तुला किती वाटलं ना तरी म्हातारी झालीस बरं का.
No, they think we are juvenile. Sorry, not jawan.
Juvenile brains trapped in old bodies. That's all.
Okay, my son is here with me, so I don't
Absolutely.
know what he has to say.
So may I start my screen sharing? I can start my screen sharing.
Yes.
Okay. Are the slides visible to everybody?
Yes.
Okay. Now, adolescent PCOS is a problem in itself. It's a different kind of problem, which PCOS as such is gaining endemic proportions. And adolescents group is now, like Madam said, 30% of our population is adolescent girls. And adolescent PCOS is almost gaining endemic proportion. So let me begin with this poem dedicated to adolescent girls with polycystic ovarian syndrome. We all know about Rapunzel. She was the girl with the beautiful hair, and she was in love with the prince who would always climb the tower using her hair. Now, in modern times, poor Rapunzel is now suffering from PCOS. So, when the prince says, Rapunzel, Rapunzel, with your hair so fine, Rapunzel, Rapunzel, with your hair so fine, let it down, I will climb it like a vine. So poor Rapunzel answers, the feat you ask, dear sir, isn't easy. I'm hyperandrogenic. My hair is too greasy. I'm insulin resistant. My weight is a rising. I may be having diabetes and also hyperlipidemia on the side. I'm often an ovulatory. I may not bear a child. I'm amenorrheic. My hormones are running wild. My poor hairy face is acne laden. So, my dear sir, please find yourself another maiden. ये बिचारी रैपंजेल की करुण कथा के साथ हम आगे बढ़ते हैं. So we will try to solve the problems that this poor Rapunzel has, and I'll now bring the first question.
Supriya,
Yeah,
can
sorry.
I interrupt you? Supriya,
Yeah, please,
sorry.
please, Nandita, tell me.
Dr. Jaideep Tank has joined, so why don't you replace him with me in the panel? I just spoke to him. So Jaideep, are you online? Maybe you can introduce him. Yeah, he's there.
Yeah, why not? Why not? Can we go back to our gallery view?
Yeah, hi, Supriya.
Hi, Jaideep.
Sorry,
I hope
got
your
delayed.
patient is fine and the baby is fine.
He's fine. He's fine. Thank you.
Great, great.
Thank you.
So, may I introduce Dr. Jaideep Tank, Secretary General of the Federation of OBGY, FOXY, immediate past president of Mumbai Obstetric and Gynec Society, Chair International Federation of OBGY, that is FIGO, Committee for Safe Abortion. He is very active in AOFOG. He's been the Vice President of the Forum for Enhancement of Quality in Healthcare, consultant at the Ashwini Maternity Surgical Care. He is highly interested in endoscopy, IVF. If I continue reading his CV, I think we'll finish the time. So welcome, Jaideep, and thanks for joining us. And since you were busy, we are starting off with the panel. I request you to please be one of our esteemed panelists, and then we'll go ahead with your talk. Yeah, Nandita.
Yeah, can I say one word about Jaideep?
Please, Nandita, please do that.
I think I've had the opportunity, Jaideep, of working with you for the last 25 years. I mean, in all the organizations also, of course, friendship is a different thing. We've known each other for donkey's years. But the opportunity that I've had of working with you in all the organizations of our OBGYN has been amazing. I think, and I don't know what our stars were. You were my secretary in MOGS and you were my secretary in FOXY. And from there, believe me, I learned a lot from you also. I think your organizational skill, your your insight into the constitution and always sticking to the right path, I think that is an amazing ability which you have, and of putting everything in perspective. I thought you made a very good precedent, and that was very premature. You were my secretary, but I'm sure you'll make a fantastic president of FOXY. But I think that insight which you've had with working in FOXY for so long, I think 12 years now, right, Jaideep? It's amazing.
No.
It's amazing. It's amazing.
20 years, Nandita.
20 years. Oh my God. Oh my God.
I joined the MPP committee of FOXY in 2000.
Yeah, and the amount of time and sacrifice that we have to give FOXY. Trust me, I've been in FOXY for 30 years also, doing all the work for FOXY. I think it is really commendable, and you have to love FOXY to be in it. And I think I want to wish you all the best in your endeavor for presidency of FOXY, and I'm really happy you've joined in, because I was planning an evening of leisure, and we had roped me in to do this panel. So now I hand over my mantle to you, Jaideep, and thank you so much. Thank you so much. Okay.
Thank you, Nandita. That's what secretaries are for.
Yeah. Bye.
Thank you so
Nandita.
much,
Thank you for
Nandita.
the
Really,
kind
thank you so much.
Yeah.
Welcome, Jaideep. Tech support, can we continue this view? You know, when you put the slides and I can't see my panelists, I'm really lost.
If you have your slides in front of you, they don't need to share your screen, Supriya.
I have my slide, but then the panelists need to see it. Now, the moment I start
Do they need
screen
it?
share,
Do they need it?
You
They're
can do
very
a
good
Supriya,
panelists.
you can
Yeah.
do a side by side view. That's an option available.
No,
You
but
can
Jaideep,
do
you
a
all don't need the slides, yeah.
no, the audience needs them, na?
No.
What is that side by side view?
so if
Madam, may I request you to
share the
kindly,
screen.
Yeah,
Ma'am, if
Seshan,
you-
tell me.
once you share your slides,
Huh.
the top you will see an option, a drop down where you can select side by side as an option. First, request you to share the slide first.
I'll start with that. You are told me to click on screen. Should I click on screen?
Yes, madam.
I did that. Okay. Now I
At
go
the
to
top, you will see view options. Just it's a drop down. Select side by side.
So
where is it?
yeah, so that became now healthier meals was in grade 6, and what are we eating?
Madam,
Okay,
everyone
yeah.
can see your slides right
Now
now.
I got it.
So-
Yeah. Please. Can you see my slides? The
Yes.
panelists can see my slides. Great. So let's just start off. Jaideep, I don't know whether you heard my poem, but I think now we'll not waste much time. Let's go ahead.
Yeah. Supriya, hear me?
Okay, now we are going to, this particular panel is dedicated to adolescent health, and that's why we would like to keep this, the answers specifically limited to adolescent age group. My slides are stuck somehow. Maitri, can you help, please?
Madam, just
Yeah.
click once in the center of the slide. You'll be able to move it.
Great. Okay. Okay. Now the first case is a 13-year-old girl who is having infrequent periods since menarche, which was 1.5 years ago. Her mother is very concerned because she has an elder daughter who is being diagnosed as PCO, and so her mother has come running with this young girl to you. Significant history wise, her menarche was at 11.5 years of age. So she's around 1.5 years since menarche. She has oligomenorrhea. Cycle interval is 45 to 60 days. She bleeds 7 days, occasionally heavy, but usually painless cycles. Her elder sister has PCOS. This is what the history we've got. Now, how would you proceed? Can I start with Dr. Girish? Girish,
Yeah,
would you like to
I'll
describe?
speak few lines with you, and then I'll take your leave because I am supposed to go to that hospital because
Please. Yes. We'll totally excuse you. Yeah. Tell me.
Yes. Extremely sorry. So in this case, the age of this girl is around 13 years, isn't it? And her age at menarche was 11.5 years. Which she has normal menstrual pattern because it is in between 8 to 12 years. And she has history of menarche of 1.5 years only, isn't it? So according to ISHRE 2018, any girl who has completed the history of or the age of menarche after 2 years can you hear me?
Yeah. I think we are losing your internet.
Yeah. So this girl, she has not completed 2 years of menarche. So she can be a case of PCOS as well as she can be a case of immature HPO axis, isn't it? And the points which should be considered that she is having the history of PCOS in her sister. So most of the time, the patients or the cases of the PCOS they are seen in the family. The clusters they are found in the family because it has some relation with the genetics also. So she can be a probable patient of PCOS in the future, but according to the definition, we cannot label this girl as a case of PCOS. Second thing, the diagnosis of the adolescent PCOS, it hinges between the history of amenorrhea, non-ovulation, and either clinical or the biochemical signs of this hyperandrogenism. And fortunately, this girl, she is not having any other symptom, for example the hirsutism or acne or anything, any
Right.
other thing.
Right.
So keeping the history of PCOS in her sister, she can be a case of PCOS in the future, but at present we cannot label this girl as having PCOS. But you have to keep a proper follow-up in this patient. You have to advise her regarding the this and all. And probably she is not in need of any medications also right now. And now you have asked me that shall we go for the USG?
Yes, that's
Actually
my
there
next
is no
question.
role of USG. Yes, actually there is no role of USG in this patient,
एक
at
हाथ
least for
touch
the
लगे.
diagnosis of PCOS. But USG should be done to rule out any other cause. I mean, for example, if there is any other problem with that girl, with problem, so probably USG should be done, and it is not for the diagnosis of PCOS, as we are doing, or we are labeling the patient as a case of PCOS only on the basis of PCOM after the completion of 8 years from the menarche, as per the guidelines.
Absolutely.
And definitely we are going to elaborate what are the findings to be seen in the USG. I know. Regarding the volume more than 10 centimeters per cube, and then presence of the follicles more than 19 to 20, and that's so and so. So in this case, probably
I think Girish has a bad connection. Hello? I think Girish has a... Sorry, Girish, can you repeat the last two lines? Your connection was not very well.
Yeah, in this case, probably the best thing should be the proper counseling of that patient, proper counseling of the parents. Then if she is obese or even if she is lean, even though she should be counseled for proper lifestyle management in the form of proper diet control, diet management, as well as the exercises. And the most important thing is the proper follow-up, because she is a probable case of PCOS, even though she has not developed the signs of hirsutism or the signs of irregular menses right now. She can land up in these problems, and she can be the case of PCOS in the future. So lifestyle management, wait and watch, lifestyle management, and proper counseling is the best management in this case.
I think Girish really nailed it. Am I okay now? Hello?
Yes. Actually, I'm getting calls from the hospital.
Yes. Girish, please, we'll excuse you. Thank you so much anyways for being with us. Thank you so much. Am I audible now?
Yeah. Yes, perfectly.
Yeah. So, So as Girish has rightly said, this is a young girl. So USG we will do to rule out other pathologies. Anyways, if we do the USG, these are the findings that we will normally be looking for. We must note that these findings may be in a young girl who is just 2 or less years after menarche. The ovaries the immature follicles may appear like a PCO. So if we have a very young girl with a sonography report saying PCO, we should always interpret it with caution. Now, this is again what already Girish has mentioned, that we will look out for other abnormalities. Sorry?
Yeah, I would like to add one more important thing.
Yeah.
In day-to-day practice, whenever we are facing the adolescent patients, most of the patients, they are coming with the chronological report of PCOS directly, isn't it? So their age, the history of menarche, the number of follicles, the size of follicles, when that sonography has been done, whether it was abdominal or vaginal, then what is the size of the ovaries, either of ovaries, nothing is taken into consideration. And most of the time, very rampantly, we are diagnosing and we are treating these patients as having PCOS. And just because of the Google University, when these girls and the parents are PCOS, they are carrying very wrong message with them. And many times they are fighting without any reason. It's the duty of obstetricians to counsel the patients as well as the parents precisely that what exactly the PCOS is, what is the relation of this ultrasonological findings with the PCOS, and when should we label any girl as having PCOS. Everything should be properly explained to the patient as well as to the relatives, probably.
Very right. Thank you so much. Thank you. Okay, so now as we are Yes. Someone wants to make a comment.
Yeah.
I'm
And they are
going.
here.
Okay.
Sandhya, yes. Actually, I'm coming with the next part of the question, so you can just add your comments then. Like we all mentioned that there is a very dicey situation when patient comes with a report of PCOS. Now my question is ki whether number one you will do any investigations other than ultrasound, and whether you will treat this patient, or whether you will label her as a PCOS to begin with. Yes, Sandhya, can you please say something about it?
Yeah, Supriya, first of all, I would like to make a couple of points. Now, we are all talking about this patient in terms of her sister has been diagnosed with PCOS.
Yeah.
First of all, I would like to know what is the age of the sister, because this girl is 13 years of age. Like Girish has pointed out, many a times they just come with a sonography report showing multiple follicles and they say, okay, she has PCOS. So
Right.
on what basis has the sister been labeled as PCOS? That is very important.
Right.
What is the family history? Whether the mother has been diagnosed with PCOS? Is there a family history of diabetes? So these are the very important parameters. There is no need absolutely in this case to do a sonography, because the guidelines are very clear cut that multifollicular this appearance is common in the pubertal age group.
Correct.
So we do not do a sonography since she does not have any other symptoms or any other problems. I would refrain from doing a sonography in this patient, because this only adds to the anxiety and it
Absolutely.
causes an over-diagnosis, which is not really going to help the family in any way. So my take on this is, first elicit the proper history as to what is the age of the sister.
Yeah.
When did she attain menarche? How has she been diagnosed as a PCOS? And then treat this girl accordingly. I would actually do nothing but just counsel them, allay the anxiety, and I would just say wait for a little more time. And if they are still worried, I would say follow up with me after, say, 6 months or 1 year. That's
Absolutely. Would Sureka like to make a comment here?
Yes, thank you very much, Supriya. I would like to make a couple of points. Now, because this patient has come to us with apprehension, and already a sister is suffering from PCOS. Now, 40% of the patients who are having a sister may have a PCOS later in life.
Very right.
If the mother is also positive, then add 10% more. So now you have to take a history from the mother also. So there is a 50% chance that this patient may be PCOS. Now, as we say, the HPO axis may be is immature and patient may have irregular cycles. Just remember that the cycles are not too much irregular. Okay, even if the HPO axis is immature, there are good points because of which the patient will have prolonged duration of her menstrual cycle, like if there is some exam, some stress or change, so these are some trigger points. If this patient doesn't have any trigger point and still she is having this kind of pattern, then we have to be alert in this case where already a family history is there. Now, if we have an opportunity to examine this patient, we should not lose this opportunity, and we should examine and find out if there are any clinical signs of hyperandrogenism, acne, what is the phenotype of the patient? Is she a lean person or is she an obese person? And we should take this opportunity to examine her well and find out if there is hyperandrogenism, is there an additional cause to it? And so we should not lose the opportunity. Again, we should examine the patient's nutritional status and find out if she is on the obese side. And of course, dietary modification and all this, we should not lose an opportunity for this patient and advise a regular follow-up so that if she gets PCOS, then we can catch it early. Because if she has PCOS and this is the patient who will have metabolic disorder later in life, because early PCOS is known to be associated with metabolic disorder in later life.
Absolutely, absolutely. I think you just nailed it. So the take-home message for the audience is that be very wary of labeling a young girl who is not even 2 years since menarche as a PCOS. Definitely, we'll keep her under surveillance. But within 2 years or 3 years of her menarche, it may be just a maturing hypothalamo-pituitary axis, and we should not be in a rush to label her a PCO, because remember, today children are very savvy with the net, and they will carry this label throughout life. And it's a very distressing thing for young girls to be labeled as PCO when they may not actually be PCO. According to the latest ASRM guidelines, USG is not recommended up to 8 years since the onset of menarche to diagnose PCO. So we don't need USG necessarily. We can diagnose her on the basis of other signs and symptoms, but at least 2 years after menarche. An ovarian volume of more than 10 ml is more important than a follicular count. The reason being, the newer machines, which the ultrasound machines with good resolution, they can count many follicles, and then we may get a false report of polycystic ovaries. So ovarian volume should be always be given importance. In a healthy girl with regular cycles and hyperandrogenemia, a polycystic ovarian morphology just plain on ultrasound should not be given undue importance. Okay. Now, management already our panelists have discussed. Counseling and reassurance, of course. Give good like this is the chance we can give them some advice about diet, about exercise, about losing weight. Treatment of specific problems. Now here, Dr. Rohan, I would like to ask you, she's just walked in and we've decided now we don't want to label her a PCO, but are there any certain hormonal investigations that you would like to advise her, or any other investigation? Is Rohan there with us? Dr. Rohan?
Madam, I think Dr. Rohan had dropped off.
Okay.
So,
Dr. Jaideep? Dr. Jaideep?
Yeah, hi.
Hi, Jaideep.
Hi, Supriya.
This is a young girl whom we have decided we don't want to label as PCO. However, she's come to us. Are there any certain investigations that you would still like to do apart from ultrasound? Ultrasound, now we have decided that we is not diagnostic unless she's 8 years post menarche. However, sometimes we still advise an ultrasound to rule out some pelvic pathology. We should not be missing an ovarian tumor, or we should not, for example, be missing a simple pregnancy. It's not that she's 13 so she can't get pregnant. So having done an ultrasound, other than that, are there any blood investigations that you would still want to go ahead with this patient?
So Priya, if I understand right, this is a 12 or 13-year-old girl.
That's true.
Whose essential problem is irregular periods.
Correct.
And not so much either obesity, hirsutism, or acne. Is
Absolutely.
that right?
Yeah.
Well, if that is the case, I am not very sure that if the physical examination is normal, I would even do a sonography, very frankly.
Right, absolutely, yes.
It is true, isn't it, that patients take a while for the periods to regularize.
Absolutely.
And unfortunately, they are rather worried, or I would say that they are not worried, their parents are
worried.
Parents
are worried, yes.
The indication for a sonography here would not be a medical indication for the patient, but a reassurance for the parents. Unfortunately, because this ultrasound will typically tend to be abdominal and not vaginal, and typically tend to maybe not have been done on the right day of the cycle, the diagnosis of this ultrasound will have to be taken with a lot of caution.
Absolutely.
For me, the most important element of the whole history is whether the periods are spontaneous or not. If the periods are spontaneous, then I would hesitate to investigate. If the periods are non-spontaneous, that means she gets periods only on withdrawal, then I would tend to investigate that patient.
Yeah, so that's very true, very true. So this girl as such needs to be just left alone, reassured, and some good healthy tips on eating and exercise. Maybe that's about it, managing this girl. So
I'm not the one to give healthy tips, but
that you can leave that to me. Okay, so now we'll proceed with the next case. Now this is her elder sister. She's 16-year-old unmarried girl who has had menarche at 12 years. So now she's 14 years. Sandhya, I think you were keen to know about the history of the elder sister. Now she is 12-year-old, had menarche at 12, so she's 4 years post menarche. Since around 14-15 years, she tends to miss her periods frequently. So she gets her periods in say 1 or 2 days she bleeds, and once in 45 to 60 days. She has been going to various doctors. Somebody has diagnosed her as a PCOS on the basis of an ultrasound because it's showing multiple cysts. She has been advised regular OC pills, low dose, to regularize her periods, but she took it for 3 to 6 months. She stopped, and the oligomenorrhea has come back. Now she's again amenorrheic for 4 months, and again now she is very concerned. So how will you manage this patient? Now we know she is in all probability a case of PCO. However, she is not having any hyperandrogenic symptoms. So how would you go about this patient? Maybe start with Dr. Surekha.
Yes, Dr. Supriya. As we know, there are two phenotypes of PCOS, and this patient is belonging to the lean PCOS type. We don't know. So you have said that the diagnosis is of PCOS, but
Correct.
whether hyperandrogenism is there in this patient or not, that is one question which I would like to ask. Okay, so though we are finding that yes, in lean PCOS also insulin resistance does exist. So that we have to remember. So though it is more associated with obese PCOS, but the underlying defect is still insulin resistance in this patient. So we have to take into mind and we have to take into consideration that lean PCOS also have prevalence of insulin resistance up to 6 to 22%. So that is where I think the investigation should be directed. And we should take into consideration all her records, what type of investigations have been done, and even though she is lean as compared to a patient who is the similar weight but non-PCOS, again we have to take into consideration the waist-hip ratio in these patients.
Absolutely.
Though lean,
yes.
they may have a problem of the waist-hip ratio. Again, the visceral fat distribution in this patient is different as compared to the similar weight but non-PCOS patient. So this is a subtle type of presentation. Though obese is an extrinsic presentation of insulin resistance, but lean is an intrinsic presentation of insulin resistance. So we need to take that into consideration. And if we want to do a biochemical diagnosis in this patient, we should look for insulin resistance. So fasting insulin levels, fasting levels of fasting sugar levels are, I think from my side, I would be doing, because without that she had always started on OT pills for regularization. But I need to decide what kind of treatment I will be providing to this patient. So apart from that, we would also like to know about hyperandrogenism. There are no clinical signs in this patient, but still I would like to do our testosterone, which I usually prefer to do a free testosterone level of this patient, and I try to find out the androgen index in this patient. So from my side, I would like to, and of course, presently she has been having 4 months of amenorrhea, so we need to decide on giving her progesterone. So there is a prolonged period of hyperestrogenism. So I would like to give her progesterone so that she has a withdrawal bleeding, and after that I would like to test her for her insulin and blood sugar levels. And as far as management of this patient is concerned, we usually provide an advice for lifestyle management in this patient. Now she is not obese, but still even if she is not obese, we are supposed to advise her regarding lifestyle management and try to find out what kind of diet this patient is having. And
Correct.
if we advise her exercise, then it should be a resistance type of exercise, because visceral adiposity is so. Even in lean PCOS, a lifestyle management
I
is
think, yeah, that's a very
required, so
important
that she
point
does
because
not
we don't want
become
her to lose too
obese
much
later
weight,
on.
but
Yeah.
she needs to
So
lose the abdominal fat. Absolutely.
yes, so
Absolutely.
she
Yeah.
should continue that. And yes, because even lean PCOS benefit with metformin. So insulin sensitizers that like metformin are beneficial even in lean PCOS, because there is an intrinsic insulin resistance in this patient. There is some practitioners have the belief that metformin may lead to hypoglycemia, but the chances of hypoglycemia is quite less in this
Less.
patient
Yeah.
because insulin resistance already exists. So that belief we have to remove from the minds of the practitioners. This even these patients benefit with metformin. So
Okay.
that is from my side. And of course, if you are thinking about cycle regularization,
Yeah, that
what
I'll, yeah, I'm
what she
coming to that
has
next. Yeah.
taken. Yes. So
Yeah.
do you want me to continue about the
Let's
regularization?
take some other panelists' opinion. Dr. Sandhya, would you like to mention now? Already Sureka has really done it very well. Even if they are not obese, yesterday we had Dr. Norman talking about so many good things about PCO, and he also reiterated the fact a simple waist hip ratio measurement, and even if she is lean, if she has more abdominal fat, she should be trying to lose that. Sandhya, now this girl has basically come for irregular menses. What to how apart from now we have various options to regularize the cycles. Would you prefer COCs? Would you prefer progesterone? Any other option that you would suggest? Considering her age, she's 16-year-old. She has epiphyses which are not yet fused. Would you be a little concerned about giving her estrogens?
Yeah, Supriya, can I first give what I would like to do in this
Sure,
patient?
sure, most definitely, most
And
definitely.
go on to the straight to the hormonal treatment. See, now this is a very, very important history. She is 16 years of age. First of all, that word unmarried has to be removed because it is not necessary. At 16, we don't expect her to be married in any ways. So that is one thing.
Except
Second,
if she's staying in B1D.
yeah, but even then it is illegal. So
Illegal, yes.
so that is one thing. Secondly, now it is very specifically mentioned that she had normal cycles till she was 15. She has achieved menarche at 12. So now she has basically got irregular cycles only for the past 1 year. Now, what we need to look at very carefully is a history again. I am a very, very strong proponent, as Dr. Norman also mentioned, that history taking is extremely important in adolescents.
Correct.
Why is she suddenly having irregular cycles? Is there some factor? Now we tend to overlook lot of things. We take it for granted that this patient is just having a normal lifestyle. We do not know this is a college and a high school age group girl, whether she is indulging in some behavior. There is smoking, there is alcohol intake, there is any intake of any substance abuse. Is she
Absolutely.
stressed? Because at this point of time, girls are very stressed. They are in the process of designing their careers, as to they are mostly in high school, they're going in college, so they have a lot of pressure of studies. There are a lot of pressures from peers to look good, to try out various things. So we need to rule out other factors which could be contributing to her having irregular cycles. That is one important thing. Now, again, she has been diagnosed on the basis of a sonography report. We've gone through this in the previous case. A sonography was not really required because she had normal cycles for 3 years. So on that basis, now this is what I said, that this causes stress. Now she's come to you, she's already been taking hormonal medications, which is sort of giving her cyclical periods for some time. And when she stops, again, it goes back. Now, if you look at it, there are two ways to look at it. She is not obese. Even if she is lean PCOS, we know that hyperinsulinemia is the culprit. So we need to address it. And we always say that if hormonal treatment does not work, then in these patients, metformin is the second line of treatment, even to regularize the cycles, because it reduces your insulin levels. It makes the insulin sensitivity more in these patients. They have a lot of insulin insensitivity. Secondly, within 3 months of metformin, or to say even 6 months, we see that the cycles do normalize.
Okay.
So I would put this patient on metformin. I would not put her on oral contraceptives for a longer duration of time. I am also a proponent of myoinositols, though I know that there is a lot of controversy.
Yeah.
We are having...
Actually, we'll come to myoinositols also in the future slide. But this is what I wanted to ask basically. Metformin in a girl who is so young and with normal sugars, you people, all the panelists concur on the fact that you will recommend metformin, right?
Yes, because it is an insulin sensitizer, and the hyperinsulinemia is the key in this case. So metformin should be given, especially once you've given her combined oral contraceptive pills and she's still not regularizing.
I can see Jaideep with her hand up. So yes, Jaideep. Actually,
I would have to,
the question, sub-question here is, for cycle regularization of metformin may not necessarily regularize the cycles right away. She's concerned about cycle regularization. So number one, can we promise her a lifelong cycle regularization? If not, what would be the counseling we give her? OC pills or progesterones, and for how long?
So I think the first thing I would have to say really is, why does she want regular cycles?
Yes.
And I would have to address that issue with her first.
Absolutely. That is actually what the point I want.
Yeah. So most of the times, these patients want regular cycles because they want to get rid of the so-called toxins or whatever may be gotten rid of with menstruation. I would think that I would first speak to her. I would explain to her that there is nothing like toxins or anything of that sort with menstruation. And whether she gets period once every 1 month, 2 months, or 3 months, it will make no material difference in her life. I will, of course, not only try to convince her, but convince her parents also, because over here, most of the times, the person driving the questions and the treatment are the parents rather than the adolescent herself. If she is saying that, no, I would certainly like, for whatever reason, my counseling skills may be inadequate in this circumstance. And she may say, well, come hell or high water, I want regular periods. In which case, I'm sorry, but Sandhya and Surekha, I'm sorry, but I would not give metformin to this patient. I use metformin extraordinarily rarely in adolescents. If cycle regularization is the aim, and I have not proven a biochemical hyperinsulinemia, there is no acanthosis nigricans, and the only evidence for hyperinsulinemia is obesity. I would hesitate to give metformin. I'm not saying giving metformin is wrong. Please don't misunderstand. I'm saying that I would not use it. And if cycle regularization is the only concern, I would prefer the lowest possible estrogen dose oral contraceptive pill. That would be my preference. And if I could use a pill with a newer form of progesterone, so much the better, because I may get some anti-androgenic benefits out of it. I will not say that this is proven in evidence, but I would say that this is something going by what the patient desires. And over here, if the desire is a regularization of cycles, then I don't think you can beat oral contraceptive pills.
So basically, now personally, even I am not a very great proponent of metformin in women who are not proven hyperinsulinemia or insulin resistant. However, the take-home message I think for this case is, number one, that we need to explain to her that regular cycle, because this is the Indian mindset. We need to have menses every month. So we need to tell her that as long as she is on treatment, her cycle will be regular. But as soon as she's off OCs, it's quite likely that she goes back to irregular cycles, and that she should learn to live with maybe a cycle length of 45 days. Personally, on my side, I usually give them 3 months of OCs if they low dose OCs. And then I explain them that every 6 weeks, she can take medroxyprogesterone acetate. So she's not overburdening herself with hormones, and she will still get her cycle at least every 7 to 8 weeks. So that's how personally I handle these cases. Now the next case is again a 19-year-old unmarried girl. She is presented with history of progressive hair on the face and body. So now her primary concern is unwanted hair growth since the last 9 months or so. On questioning, her periods are also occasionally delayed for a couple of years, now couple of last years, and her menarche was at 13 years of age. Now first question is about the scoring of hirsutism. Do any of you in your clinical practice go take that special effort and do scoring of hirsutism? Surekha, would you like to make comment? You'll have to unmute yourself. Surekha, please unmute yourself.
Yeah. Yes. Again, as Sandhya has said, that the history is very important in this patient.
Correct.
So, the medical history, we should talk with the patient. What is exactly the age of menarche, the thelarche, pubarche? So we have to go into when the exactly the hirsutism has started, and is there, and how is the progression of the hirsutism? First of all, is it a rapid progression? So rapid progression may indicate rapid onset, and not only hirsutism. Is there some virilization, deepening of voice, frontal balding? Right. So all that may point us toward another etiology like an androgen secretory tumor, which we should not miss. Okay, so and of course the scoring is important. So scoring, again, family history of hirsutism is there or not? Is she having acne? What is the severity of the acne? And is it a mild variety, moderate variety, severe variety? So all those type of scoring I would like to do, and definitely a clinical history and examination are important in these patients. And of course, we would also like to know how much she is concerned about the hirsutism.
Correct.
Okay, if it is not of concern, sometimes what happens, patient walks in the OPD and we notice that she has upper lip hair. And if we ask her, are you concerned about it? She said, no, this is normal for us. We say she has hirsutism, but she actually isn't concerned about it. So if what is her concern, we should find out. And then we can go and do the physical examination. In the physical examination, the body mass index is important, the blood pressure is important, then so these the waist hip ratio, these are all important things. What is the kind of obesity? Is it a centripetal type of obesity? Are there any skin tags? Is there acanthosis? So these clinical findings again are important. So the Ferriman-Gallwey score, as you have showed in the picture, scores it from 9 areas of the body, and score greater than 8 is indicative of hirsutism. Right. But though we may not go into grossly scoring, many a times we just we do not go into the complete scoring, but still, so if you want to do it well in an institutional setup, we do recommend a Ferriman-Gallwey score, but I don't know.
It is excellent. Of course, it's a very good scoring system. Yes, but the concerns are that there are a lot of ethnic differences. So, like for example, Indian ethnicity, there is what we have studied even in undergraduate level, that Indian ethnicity people are overall more hairy than say Oriental races. The Caucasian races are overall more hairy than the Oriental races. So
yes, this is type, so chest hair and
so certain areas. So that is what I would like you to comment, that certain areas like on the upper lip it can be even familial, but if it is on the chin, the sideburns, the medial side of the thigh, on the abdominal wall or perioral, these are specifically indicators.
On the back also, areolar.
Yes, and back, lower back, absolutely.
Buttocks,
absolutely.
These are the areas where we should look into. And if there is, these are the areas, and of course the coarse type of hair, if it is there, then possibility is there that this patient does have hyperandrogenism, and which needs to be managed. Now,
Right.
this is what I think you had asked about. The
Yeah.
focal hirsutism is very important, and we have to remember that the hair which is already existing may not benefit with the whatever medication or therapy
Yeah, about to give.
you're
Right.
going to provide. So
Yeah.
we need to offer her a cosmetic evaluation and consultation in this patient, because this hypertrichosis which we are talking about will not respond. So cosmetic evaluation, dermatological evaluation is important. Apart from that, I would also evaluate the patient for the type of androgen which is in excess. So sometimes what happens, a late onset type of we should not miss the this your hyperandrogenism, and I'm forgetting the name, but we have to do the 17 hydroxyprogesterone level in these patients. We should also do the free testosterone levels, and I will also do the SHBG levels in these patients. Okay, so for my institutional setup, we do the and if we are suspecting the cortisol levels also, late onset, we need to
Yeah.
evaluate this patient for
Yeah.
congenital adrenal hyperplasia.
Hyperplasia.
Apart from that, we can also examine the genitalia, and if there is look at the genitalia, if there is some sort of abnormality there, then again we need to score if there is an important, is it like a small phallus type of enlargement, is if there of clitoris, then we need to measure the width and the length, and we are able to diagnose if this is a severe kind of hyperandrogenism, and accordingly then of course we can decide what kind of treatment you are going to give. If the testosterone level is more than 200 nanogram per dl, then it suggests that there is a virilizing tumor, which you need to do an ultrasound and find out if there is an ovarian tumor or if there is an adrenal tumor which you are missing. So if you suspect that, then of course the ACTH stimulation test, the cortisol level, these will come into being a non-classic type of adrenal hyperplasia. If your congenital adrenal hyperplasia, you may miss sometimes, and this may point towards it. If you have ruled out everything and you find that it is only PCOS which is causing this, then of course the management of hirsutism, the existing hair, could be managed with the help of your dermatologist. You can advise various type of treatments like epilation or laser, or simple patients may need to take into, I think my battery has some problem. Please go ahead, Sandhya. I'll need to take care of this the battery.
Yeah, please do, please do. Sandhya, I'm coming to you now. This patient has come in a private setup, like you and me are doing private practice, and she would like only a handful of tests to be done. She doesn't want to waste too much money and time. What would be your recommendation? Now we have this list of differential diagnosis. Any particular few tests that you would recommend to be done as a part of her investigation armamentarium before proceeding for managing her?
See, it is a very specific according to the guidelines which you have mentioned. Documentation of adolescent PCOS is basically we have to document hyperandrogenism. We already know one is the ovulatory dysfunction, secondly is to document biochemical hyperandrogenism, for which there are a lot of testosterone assays. We had this discussion with endocrinologists also over the past so many years. And it has come to a consensus that the assays are basically unstable. So we need to have a lot of standardized assays, which the only possibility is calculated testosterone. The calculated free testosterone is the only one which should be used, not the direct free testosterone. That is one thing. Secondly, we can use the total testosterone in this case, since she already has hirsutism. So we know she has got a hyperandrogenism. So this is the only thing that, the patient needs a reassurance. From our side, frankly speaking, in our
Absolutely.
practice, we do not
Yes.
all these tests. We do not do all these tests. We tell the patient it
Absolutely.
is not required. Neither our endocrinologists recommend us to do even insulin levels. If she has evidence of insulin resistance, we know that she has this problem. We need to treat it. We need to treat the symptoms. We need to treat why the patient has come to you. When I was saying metformin, I meant I am also not in favor of treating adolescents with metformin, but if necessary, we give it, but for a very short period of time, only for 6 months, and then we assess the patient again. And if we feel that she is symptomatically better, then the crux of the problem lies in reducing the insulin levels. Now, that can be done. There are many schools of thought. First is you can diet and exercise. There is no substitute to that. Even if she loses 5 to 10% of her weight, then definitely her level of hirsutism, acne, everything comes down. Secondly, if she improves her diet and her metabolism, these things get resolved to a large extent. Thirdly, we can treat hirsutism, we can treat her abnormal cycles also, we can give low dose combination pills, and if required, we can add CPA if the hirsutism is distressing her to a very large extent. Otherwise, we do not recommend. We give a very, very low dose of estrogen and progesterone combination if at all required. Within 6 months, we have seen the hirsutism does come down. And if the patient is very cosmetically conscious, then there is a large armamentarium. But the dermatologists still say that laser reduction doesn't work very well if it is done before the age of 21. So we have to take a lot of things into perspective as to what she really wants and what you are able to offer and what she is going to be compliant with. That is very important. These patients keep going to one gynecologist, dermatologist, cosmetologist, and they are frustrated.
And actually, yesterday, this same panel case was discussed in the Foxy platform also, where again, most of the senior doctors are of the opinion that if it is an established case of hyperandrogenism, then doing a battery of tests to prove it is not going to give you any extra information. However, you must do them if you are suspecting a virilizing tumor, as rightly said by Dr. Surekha.
The only test which I would really recommend in this patient is a OGTT. That is very important.
Yes, absolutely.
OGTT.
So we make sure we are not missing, diabetes, overt or covert diabetes, either ways. I think you just nailed it. Now, Sandhya, your opinion about anti-androgens? Whether you use anti-androgens in such cases apart from the cosmetic treatment?
I do use sometimes anti-androgens, but again, I do not use them for a very long period of time. I use them for maybe 3 to 6 months. That is it. I have seen patients, once you prescribe it, they just go off. I have seen a patient on anti-androgens for 5 years, 10 years.
OMG.
With a long, they are just available over the counter. So you have to be very careful. You have to see the patient who is likely to come back to you and then prescribe them. Because as we all know, CPA is not available in the US. So it is basically our country.
And it is so freely available in India. That's quite surprising.
So it is not a very good thing to put them onto these because they give it to their friends also. It's not your patient, but they give it to their own friends. The whole school is taking because there is nothing like, you need a prescription sometimes, which is very sad.
Yeah, so just summing up this case, clinically hirsutism, acne and androgenic alopecia are ample evidence that she is hyperandrogenic. Documentation of biological hyperandrogenemia is to be done only if you need to exclude other causes. If you are suspecting like tumors or something like that, or congenital adrenal hyperplasia, we need to counsel them that correction is going to take time. This is one thing that the children need to understand, that there is no miracle remedy and that it's going to be a slow and really prolonged process, and hormonal therapy has to be given in association with cosmetic therapy. Now again, Sandhya, I would like to start with you. This is the last case, and since we are running behind time, we'll just quickly go through this case. Now this is an 18-year-old girl, irregular menses since 13 years of age. She has been putting on weight since the last 4-5 years. At present, she is not pregnant, no significant drug history. Her mother is obese, diabetic, and hypertensive. Her weight is 83 kgs, BMI 38, waist circumference 38.6, no acne or hirsutism, a blood pressure of 130 by 80 millimeters of mercury. Now, how will you investigate this patient? Now, we are probably dealing with a metabolic syndrome in a case of PCOD.
Yes.
So,
Now, since we are running short of time and this is a very clear-cut case, this is a metabolic syndrome. According to the guidelines, which are recent guidelines, any patient who presents with a metabolic syndrome, you have to do her lipid profile, you have to do her OGTT. This patient needs a lot of surveillance. Her blood pressure has to be kept under control. Now she is a BMI above 35, which is very dangerous. So in these patients with a BMI of about 35, metformin is not known to work very well. So you have to try and get the BMI down to 35 at least. So in that case, I would stringently advocate a weight loss regime to her. If she is not managing to lose weight, I would definitely refer her to a weight loss expert or to a nutritionist, or to advise some way where her BMI comes down to 35. Because in this 18-year-old, bariatric surgery again is not an option, because these patients want a quick fix. So there are no quick fixes. Now this patient has comorbidities. She's definitely going into diabetes. She's going to go into cardiovascular risk factors. She has a family history, a very strong family history. So I will be very careful with this girl, and I will really counsel her a lot. I will try to motivate her. The bottom line is she has to exercise, lose her weight, and then we go on to other therapies concomitantly. But she will require also an endocrinological support along with a gynecologist.
Correct. Definitely her thyroid and prolactin should be done. Other than that, we have this list here where, like rightly mentioned by Sandhya, sugars should be given importance, and an OGTT rather than a sugar fasting PP would be preferred. Surekha, my question?
Yes.
As this is for the sake of our audience, that AMH is not considered as a diagnostic criteria. I have seen so many young girls coming with AMH report. Please don't waste their money. It's an expensive test. A simple waist to hip ratio is what we should be doing rather than doing an AMH. Surekha, I would like to get from you metformin, myoinositol. What is your NAC? What do you recommend? This is like a big Pandora's box.
There has been a lot of studies going on regarding metformin and inositol both. These both are insulin sensitizers. Because we are short of time, I would like to say that what the research has said, that metformin is much better as far as though inositol also, the myoinositol has been shown to be an insulin sensitizer also, but it does not. Metformin reduces the ALH level, it reduces the androgen as such. So these effects, the biochemical effects, are not well seen with inositol, they are more seen with metformin. So my first choice is always metformin, and up to the dose of 1500 milligram per day. So even in lean PCOS, obese PCOS, I do prescribe metformin, but even in lean PCOS who are not responding to your OCs, you are given for so much amount of time but not responding, then I may put on metformin. And in those patients who do not respond to metformin, and that is where I may switch over to myoinositol. I don't know what other the panelists would agree to this or not, but yes, and if I need to choose between myoinositol and dechirioinositol, then I choose myoinositol. Okay. So that is what my practice is.
Jaideep? Is Jaideep there?
I'm here.
Metformin, myoinositol, NSE, berberistin, or what you may. What is your recommendation?
Well, over here, I think I agree with what Sandhya and Surekha have said. In terms of the fact that it would be metformin if there is hyperinsulinemia or even hyperglycemia as the first line of treatment, followed by the inositols, and either of the inositols. But I think I agree with what Surekha said, myoinositol before Cairo. Having said that, let me qualify it by saying that the evidence for the inositols is not really very strong just now. So I would understand that I'm using it more as an empirical therapy rather than as a therapy as sort of an end therapy or a definitive kind of a
Absolutely, yeah.
therapy. But I think I pretty much agree with everything.
Okay, metformin and myoinositol, how long therapy would you recommend? 6 months, 1 year, 2 years, 5 years? Any of the panelists can answer
Well,
this
the
actually.
short answer.
Yeah, because see, this is we
Why don't
we have
Surekha
people in
and
the
Sandhya, why
audience
don't you answer
who
it?
would like
Because-
to practically answer this question. You know, patient walks in, she's been taking 6 months of inositol already. Would you ask her to take another 6 months? So, just can we have just
So
like
now
a
these
guideline?
are problems which are not yet solved through our literature is not mentioning for how long. So we need to remember these are all adjunct therapies. They will not. So remember that metformin or either metformin or myoinositol is not going to cause any weight reduction first of all. So these
Absolutely,
are the
yeah.
lifestyle management and reducing your weight. These are the prime therapies, and we need to ensure that our patients are actually. My puppy is giving me trouble,
Okay, okay.
because I'm being on the So we need to remember that we need to look at the lifestyle management and of course I won't recommend that maybe 1 year or 2 years of metformins. I don't recommend that way. So that's
Correct.
not my recommendation. Maximum I would go is for a year or maximum 2 years.
Okay, so 6 months to 1 year, I think is a fairly good interval when we should be rethinking
Yeah.
about it.
I
Vitamin D, anybody of you who uses vitamin D?
I was just going to come to that. So you asked me, Supriya, about this thing. There is only one thing. See, I'll tell you, the world literature, there is a lot of studies on metformin. It's been documented. The reason why we say no to myoinositols is because there is no standard evidence. But there is a huge trial going on. There is a huge study going on.
Yes.
By the end of the year, we will have more results. What we have learned from the stalwarts of PCOS worldwide is that they are looking at India because we are using myoinositols more than anybody else in the world. So they depend on us to give them the literature and they depend on us to give them the statistics. So this is what we are working on, and I think we should have good answers because many of our doctors are having good results.
Right.
We, by and large, say do not use for a very long time, but yes, up to 9 months or 1 year is fine. And vitamin D has a very big role. I have given a talk on, is it a new endocrine organ, a vitamin D? So we do supplement vitamin D because we say that we are a country, a tropical kind of a climate, but our children are not going out, they are not playing in the sun, they are not exposed to sunlight, and we do need to supplement them with vitamin D also.
Right. So would Jaideep like to make a comment or should we just wind up the panel?
Okay, I think you can go ahead, Supriya.
Yeah. So basically, any adolescent PCOS, these are the basic investigation that absolutely you must do. These are the 5 tests. Remember, PCOS is a diagnosis of exclusion. Once you have ruled out everything else, like a diabetes, like a hypothyroidism, hyperprolactinemia, of course, can be in conjunction with PCO. Only then you can label her as an exclusive PCO. The take-home message basically from this panel is that adolescent PCO, they should be labeled very cautiously. The mainstay of treatment is lifestyle change. You have to tell them weight reduction, exercise and diet is the mainstay of management for them. If they have menstrual irregularities or acne or hirsutism, so specific treatment to be given. Insulin sensitizers, if she is having metabolic syndrome, they should be warned about the long-term sequelae like obesity, like type 2 diabetes, like endometrial cancer, for which they should be on the lookout. The patients need to be counseled that it is a metabolic disorder. They have to live with it for a lifetime. Anovulation may be a problem, but since we are talking about adolescent age group, which is not really concerned with childbearing, they need to be, or the mothers basically, they come with a lot of anxiety whether she'll get pregnant in the future. Yesterday someone made a very excellent comment that mother is concerned about future fertility, the child is concerned about present, presentability, whether she is having acne, whether she is fat, whether she is hirsute. So the two generations are concerned in different things. So basically counseling, insulin sensitizers do play an important role, especially if metabolic syndrome is there, and long-term follow-up is a must. That is something that we need to reiterate, that even whether we give them long-term, short-term treatment, they need to follow up with us. So may I take this opportunity to thank my panelists, Sandhya, Surekha, Jaideep, Dr. Girish. Unfortunately, Rohan could not join in, but thanks to you, and I hope the audience has got lots of good take-home messages from this panel, which can be practically used for their, clinical practice as a routine. So, without much ado, we would like to now go ahead with Dr. Jaideep's talk on adolescent endometriosis. Already the honors have been done and the formal introduction has been done. So I think Jaideep, Manor, just stop slide sharing. I'll stop my slide sharing so you can immediately start off. Yeah.
Right, I'm just sharing my slides. Right, so the two most common questions since the lockdown began, Supriya, are my slides seen and am I audible?
Yes.
Yes, okay, thank you, Sandhya. Okay, so it's a real pleasure to be here. I do apologize. I was held up in a cesarean and it was a second stage cesarean, so it took a little while. And I'm sorry that I was delayed in joining the webinar.
Please don't embarrass us. We all are obstetricians. We all understand the importance of being absent in important events. Yeah.
Sure. Thank you. So let me begin then first by thanking the moderator, Supriya, for putting this together and also for inviting me. I think I've known Supriya since our days in Wadia Hospital, and she is as bubbly and effervescent as ever. And of course, her shairis and poetries always continue to amaze me. I don't know how you remember so much, Supriya. And I'd also like to thank the president, Nandita, the vice president, for this quite lovely series of webinars that you have been having in AMOGS. And of course, my co-panelists today, Girish, Sandhya, and Dr. Surekha. Rohan could not unfortunately make it. He was there for a while, I think, but then he had to leave. I will quickly try and take you through my thoughts on endometriosis in adolescents. And we will first start by looking at incidences, symptomatology. We'll then move on to treatment, both medical as well as surgical. And then we will look at some other miscellaneous considerations when we talk about endometriosis in adolescents. Let me begin though by showing you the slide, and those who have heard me presenting earlier know that I do like to start with the slide. This is a screenshot of a Medline search that is done on endometriosis in adolescents. In fact, this Medline search has been done today afternoon. And what I'd like to point out here is the graph which comes whenever you do a Medline search. That graph tells you about the number of articles that are published every on the topic. So if you have a graph which starts tall and then keeps going down, it means that the number of articles on that topic have been going down every year, and either perhaps the topic has lost relevance or all the questions which surround the topic have been answered in literature. If, however, you find a graph like this, which starts small and then keeps on increasing, it's quite obvious that there are a lot of articles still being published on this issue in literature, and therefore the topic is very much current, relevant, or look at it in another way. Although there are a lot of articles, we still don't know what we are doing as far as this topic is concerned. So let's start by looking at the incidence of endometriosis in adolescents. It is said that almost 10% of the general female population, not adolescents, general female population has endometriosis, but a subgroup of patients who have chronic pelvic pain, the incidence of finding endometriosis is close to 80%. There are really no consensus on what the actual incidence of endometriosis is. The range that has been proposed is right from 19% to 73%. It is, however, clear that in adolescents who present with chronic pelvic pain or dysmenorrhea have a fairly high incidence of endometriosis. So, as this ACOG article says, at least two-thirds of adolescent girls with chronic pelvic pain or dysmenorrhea who are unresponsive to hormonal therapies and NSAIDs will be diagnosed with endometriosis at the time of a diagnostic laparoscopy. So you have a sort of a triaging, if you will, of making a diagnosis of endometriosis in adolescents. There's chronic pelvic pain or dysmenorrhea, and then there is a subgroup who does not respond to medical therapy. And then in that third kind of a triage of this subgroup, you will have a fairly high percentage of patients who have endometriosis. Do adolescents have a different symptomatology for endometriosis as compared to adults? Well, some literature seems to suggest that adolescents are actually more likely to present with non cyclic pelvic pain. Now, this is a fairly important symptom and a symptom which is a little different from what we see in adults, where they mostly present with cyclic pelvic pain, typical endometriosis pain, premenstrual, maximum first 1 or 2 days of menses, and then the pain starts going down. If at all you do a laparoscopy for an adolescent, keep in mind that the endometriotic lesions which are visualized in adolescents are considerably different from the lesions which are seen in adults. Subtle and atypical lesions are more commonly seen in adolescents, even higher than what you see in adults. So the most common complaints for adolescents and endometriosis is essentially, as I said, dysmenorrhea, menorrhagia, and surprisingly enough, a large number of them have at least one gastrointestinal symptom, and 52% have at least one genitourinary symptom. So that gives you an added clue on history by saying that if you have pelvic pain or dysmenorrhea and you have a GI symptom and genitourinary symptom associated, you are more likely to be looking at an endometriosis than not. The next question you need to answer, and this goes actually to the way we perceive the etiology of endometriosis. Classically, we thought that endometriosis resulted from a backflow during menstruation, which caused endometrial tissue to go through the tube and then deposit itself in the pelvis. If that were true, adolescents who have menstruated the least would tend to have only grade 1 or grade 2 endometriosis. However, you know that this theory has some flaws because a lot of adolescents also present with stage 3 and stage 4 endometriosis, which gives rise to that interesting theory that advanced stage endometriosis perhaps represents a completely different entity as compared with early stage diseases, which may actually have a genetic origin more than anything else. So I think this is something which we talked about when we were discussing PCOS, and which is the dilemma of pre-op or empirical treatment. And why is it a dilemma? Because endometriosis could present with any combination of dysmenorrhea, deep dyspareunia, pelvic pain, infertility, or a pelvic mass. The predictive value of any one symptom set of symptoms remains uncertain, and endometriosis is often found coincidentally in asymptomatic women. This problem is compounded by the fact that there are currently no bioavailable markers for the diagnosis of endometriosis. There's no one test, non-invasive test that you can do and say, okay, if this test is positive, this patient has endometriosis. Laparoscopy was and is the gold standard for diagnosis. But do you want to do a laparoscopy for all adolescents where you suspect endometriosis? That would be quite facetious, wouldn't it? So Even the ESHRE guidelines, which is the highest rated guideline, an interesting side note over here, in a review published in the BMJ on guidelines, they found that all guidelines, including RCOG, RANSCOG, Canadian, American, ESHRE, from all these guidelines, there was agreement within the guidelines on only around 7% of all recommendations. So when you talk about endometriosis, if different people tell you different thing, it's not surprising. Even the guidelines don't agree. But for this particular purpose, this is actually one of the few things in which guidelines do agree that pre-op treatment, even without a diagnosis, is reasonable amongst adolescents, patients who are unable or unwilling to undergo a laparoscopy or before a second look laparoscopy. What does this mean? It means that if you have made a tentative diagnosis, and mind you, it's a tentative diagnosis because the gold standard is laparoscopy, then it is reasonable to treat adolescents empirically with whatever you may want to use for the treatment of endometriosis. Now, if you want to treat them empirically, what are your options? You have NSAIDs, you have OC pills, you have Dynogest, Agonist. Mifepristone has been suggested, but I would consider that mifepristone is still experimental. Dynogest has been recommended as an excellent treatment, particularly when there is pelvic pain. In fact, I would go to the sort of an extreme and say that you wouldn't really want to treat adolescents for endometriosis until they have symptoms. And the most common symptom, as we have seen so far, is in fact pelvic pain, either chronic pelvic pain or dysmenorrhea or non-cyclic pelvic pain. So your first option could be Dynogest. The problem with Dynogest may be that you would be a little concerned about the bone health of an adolescent, because bone health is typically very, very important in adolescence. You could consider a GnRH agonist with an add-back hormone therapy, who in patients where Dynogest doesn't seem to give a good response. There is no sort of a one versus the other as far as Dynogest and GnRH agonists go. So, as far as medical treatment is concerned, you are mainly treating them for pelvic pain, either dysmenorrhea, chronic, or so on. Your options, as I already said, would be NSAIDs first, followed by OCs, followed by Dynogest or GnRH agonist. You would very, 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 very rarely need to do a surgery for an adolescent. Before you decide to do a surgery for the adolescent, I again urge you, think at least 10 times before you scope an adolescent for pelvic pain and dysmenorrhea. Another thing which comes up often is adolescents presenting with endometriomas. They go to a sonologist because of the pain, and then they come back with a report, sometimes saying 2 or 3 or 4 centimeter endometrioma. The question then is what to do. If it's a very large endometrioma and that person is asymptomatic, I would still tend to leave that adolescent alone. The whole issue here is of pain versus no pain. I mean, for me, that is the deciding factor as far as the treatment is concerned. However, if you do decide to operate on an endometrioma in an adolescent, you have to decide what kind of surgery will you do. Will you do a cystectomy, or will you just open the cyst and then do a fulguration of the active deposits? The question of to aspirate or not to aspirate quite clearly has been resolved in favor of not to aspirate. It's very tempting to aspirate an endometriotic cyst, and I have also done it very, very occasionally. But I must say that recurrence rates are extraordinarily high with simply doing an aspiration. So, particularly for adolescents, if there is one thing I can tell you, and one thing you can remember from this lecture, it is that all endometriomas do not need treatment. In fact, for adolescents, I would say most endometriomas should not need surgery or should not be operated upon. If you are looking to decide whether you want to do a cystectomy versus just opening the cyst and fulgurating it, let's get one thing very clear. Excision will always have a lower recurrence rate. If you are simply going to open the cyst and fulgurate it, your recurrence rate is certainly going to be higher. So if you are comparing a cystectomy versus drainage and coagulation, you have to see why you are doing it. If you are doing it for pain, then yes, you may consider doing a cystectomy and a very complete kind of an endometriosis procedure. But remember that every time you remove the cyst or you excise the cyst, it doesn't matter how skillful of an endoscopic surgeon you are, you will be removing some part of the ovary. This is a very interesting study from Romania. What they did was they went back and looked at all the histopath samples of 60 cases of endometriomas. The ovarian parenchyma was found in 40% of the cases of endometrioma cystectomy. Another study, which was reported in Fertility Sterility in November of 2018, quite clearly showed that AMH levels continue coming down for 6 and 12 months after an endometrioma stripping surgery. When you are talking about adolescents, remember that ovarian reserve is extraordinarily important. The ovary is quite vulnerable to surgery, and so although excision may be the treatment of choice, it may be deferred because over here you are worried about the ovarian reserve. What about cyst wall coagulation? Does cyst wall coagulation also compromise ovarian reserve? Although there are no studies in adolescents, there are studies in IVF which seem to suggest that cyst wall coagulation, if done judiciously, does not compromise the ovarian reserve. Again, you should very rarely operate on adolescents with endometriosis, but if you do, consider the diagnosis incomplete without a tissue diagnosis. Remember that cancer may lurk in large endometriomas, and sometimes a laparotomy may be a preferred mode of surgery over a laparoscopy. So, if you are going to operate on an endometrioma in an adolescent, first of all, it would be very rare that you should need to operate. And if at all you're going to operate, please consider a more conservative operation rather than a fairly radical cyst removal. If you are suspecting severe endometriosis in the adolescent, your approach should be guided by the symptoms. Does the patient have pain or does she have no pain? If she has pain, you can go ahead and consider surgery after trying all the various kind of medical treatments. But particularly in adolescents, remember that discretion is the better part of valor. Please don't try all those very, very complicated surgeries and endanger her bowel and bladder and all her surrounding viscera, not to mention ovarian reserve, by doing very radical surgeries for these patients unless they have very, very intractable pain. There is good evidence to show that the best surgical approach to deep endometriosis is unclear. And although for pain related to endometriosis, laparoscopic surgical removal of endometriosis is an effective approach, you still need to be very conservative with the ovarian reserve for these patients. So, in the very, very rare circumstance, if you have operated on a patient who has severe endometriosis and pain, you could do the adhesiolysis first, you drain and treat the endometrioma. Use GnRH if you are not satisfied with the end result in terms of removal of the endometriosis, and only consider a second look scopy and SOS adhesiolysis. I've written IVF is a good option for fertility, conscious of the fact that we are talking about adolescents. If you have an adolescent with some parents who are extremely curious and knowledgeable and so on, you could even offer fertility preservation. But frankly speaking, I have not done a single fertility preservation for this purpose as of now. So, when at all you do a surgical approach, remember that the ACOG does not recommend peritoneal stripping in adolescents because there is, theoretical concerns about adhesion formation, etc. In addition, there is a lack of short-term and long-term data. And although surgical therapies have been proposed for primary dysmenorrhea, remember that the evidence which is backing either uterine nerve ablation or presacral neurectomy for dysmenorrhea is rudimentary, to say the least. So, do not suggest laparoscopy to detect and treat superficial peritoneal endometriosis. Yeah, this is for infertile women, but of course, the same could apply to adolescents. And do not perform laparoscopy in adolescent women with moderate, severe, and clinically suspected early endometriosis without prior attempting to relieve symptoms with either OCs or GnRH agonists. Do GnRH agonists, are they really effective in the long term for pain? Well, if you're going to use GnRH agonists, then be prepared to use them for 6 months rather than 3 months. There seems to be quite a lot of difference in the outcome if you use agonists for 6 months rather than 3 months. If you are worried about the lack of hormones, you can do add-back therapy. Add-back therapy has not been shown to affect the therapy that you are giving. If again, perchance, you have operated on a patient, should you use hormonal therapy? The short answer is it pretty much depends on how much endometriosis you think you have left behind. If you have left a considerable amount of endometriosis behind, then you should certainly consider either OC pills or GnRH agonist as a treatment. So, if you look at it in a broad picture, you are essentially going to base your diagnosis and your further management depending on the presence or absence of pelvic pain. If there is pelvic pain, give empiric treatment, and if she responds to therapy, then continue the empiric treatment. If she does not respond, then investigate her, and if there are positive findings and she still does not get relieved, then only consider surgery. So the primary treatment is always medical. The recommended treatment for endometriosis is conservative surgical therapy for diagnosis and treatment combined with ongoing suppressive medical therapy to prevent further proliferation. But I cannot say this enough number of times. It should be extraordinarily rare for you to operate on an adolescent for relieving her of endometriosis. Patients with endometriosis who have pain which is refractory to conservative therapy do benefit from 6 months, not 3 months, 6 months of GnRH agonist therapy. NSAIDs can be used, and adolescents should not be prescribed narcotics long term to manage endometriosis. So I'd end with this slide from one of my favorite directors, Woody Allen, who said that it's very difficult to make predictions, especially about the future. And this is so typical of endometriosis, where theories, treatments, and the way to approach patients seems to change with every article that is published in literature. If I'm lucky enough to be called by you a few years later, I may land up telling you something which is completely different. So thank you very much for a patient hearing.
It was awesome.
Fantastic, Jaideep. You absolutely nailed it. I mean, this was fantastic. Is Surekha here? Surekha is signed out. Okay, there are a few questions. I'll quickly take them. Just give me a second. Okay, there are a few questions from our delegates. Please do note that there are 416 odd people watching this program online. So it's a great number that we've got to put together. Now, the one question is a 20-year-old with increased serum testosterone and DHEAS with oligomenorrhea and hair fall. Treatment with OCs regularizes the menses, but the hair fall persists. After 10 months of OC, her testosterone level has increased. Any suggestions? Any suggestions, Sandhya, Jaideep?
Sandhya?
See, now there is, if she's having an increase in her testosterone levels, then definitely, like we said, we need to rule out any other disorders, because there is no reason why her testosterone levels should be increasing. Does she have any androgen secreting tumor? That is one thing I would like to really rule out in this patient, because androgenic alopecia is a very common symptom which we see when there is severe hirsutism. So I would first like to reassess her. I would like to also see whether she is taking her medication properly. At the same time, for hair fall, there are so many therapies. I would like to refer her to a dermatologist, because the alopecia, if it is left untreated, can cause severe hair fall. So it needs to be treated concomitantly. So I would do all three: reassess, again investigate, and refer her to a dermatologist. All three.
Oh, thanks. The next question is that often doctor has put in that often they see cases of PCO with small size uterus, and they are for treatment for infertility. So how do we go about it?
PCO with a small size uterus.
Yeah.
So first, I'd like to know the definition of what is a small size uterus. I mean,
I think they should be reconsidering the diagnosis, whether there is something else going on.
Yes.
Like we said, the sonologists and maybe the gynecologists also are very free in giving their diagnosis of PCO. We have I think every third patient we label as PCO purely based on some follicles growing in the periphery. So
yes.
I also personally feel that the diagnosis needs to be reconsidered.
Yes.
Can I just say?
Yes, please, Jaideep, please.
No, I think rather than looking at the uterus, one needs to look at the pattern of the endometrium in these cases. So if you have, for example, a uterine cavity with an endometrium which is showing cyclical changes on ultrasound, then the size of the uterus pretty much does not matter. Because if you look at it in context, in a normal pregnancy also, the uterus expands to more than 20 times its size. So the size of the uterus, according to me, is irrelevant as long as there are no rudimentary horns or it's not a biconvate uterus, means there are no Mullerian anomalies, and two, that the endometrium is undergoing cyclical changes. If you're getting a good 3-line endometrium at the time of ovulation, then that's all that matters really.
Right. Okay. Now there is this. Sorry. Where is it? Just give me a second. What's happening? Yeah. Now this one question is from Dr. Neena Pachapurkar from Navi Mumbai. What are the recommendations in such situations of RCOG or ESHRE for metformin in adolescent? I think that question we already addressed. That preferred in case of proven metabolic syndrome or insulin insensitivity or insulin resistance, rather, as we call it. And I think up to 6 months to 1 year. Is that right?
I'll rephrase it properly. See, basically, metformin as such, the NICE guidelines have very pointedly mentioned about it. When you're using combined oral contraceptive pills for cycle regulation, only if you feel that you're not attaining the desired effect, then you can add metformin in that case. But if it is for a patient who has insulin resistance or who is overweight, then you can use metformin as the first line of treatment. Now, regarding as to the duration, yes, 9 months up to a year is fine, but these patients have to be monitored. See, metformin does have a few side effects on the liver also. Yeah. So we need to monitor her. She needs to be monitored. And secondly, we say that metformin and COCs work better when the BMI is less than 35. So if it is about,
first and foremost, we should ask her to lose weight.
Yes, between 30 and 35 is when metformin works very well. If the BMI is very high, then metformin does not work very well. If the insulin levels are extremely high, then also it does not work very well. So there are very specific indicators.
Okay, Jaideep, there are lots of questions for you. I'll just quickly go through with them so you can answer them.
Sure.
Because it's now a time to wind up. We are like 1 hour behind our schedule, but it's been such a lovely session and so informative with so many people joining and keenly asking questions. So it is my duty to put them across to you. Dr. Nihitha says, after 3 months of treatment with Dynogest, no response. What next? Dr. Surbi has put a question: dose of Dynogest and for how long?
Can I just answer, Supriya? Can I just answer one by one as you're asking?
Yeah. The Dynogest questions I'm putting together. Dynogest question, the question for Dynogest, the dose, how long, and after 3 months of therapy, if there is no response, what next?
Okay. So the literature has said that you can use Dynogest very safely up to 50 weeks, which is oddly specific for something in literature to say, if you ask me. But it all depends on what you're giving the Dynogest for. If you're giving it for pelvic pain, you could consider using it for a longer time also. in a sense, you should use the lowest possible dose, which is 2 milligrams once a day, till as long as there is pain relief. You should normally start seeing pain relief at the end of around 4 to 6 weeks. That's the latest that you should start seeing pain relief. If you're not seeing pain relief in that much time, don't wait for 2 or 3 months before you switch to something else. You then need to either look at hormone or GNR for these patients. So the short answer is 52 weeks is the maximum recommended in literature. Again, oddly specific, but I'm sure you can use it for a longer time. 2 milligrams is the minimum dose, and if it doesn't work in 4 to 6 weeks for pain, move on.
Okay, Dr. Sudha likes to know whether we should continue Dynogest when we are giving her infertility therapy also.
No, the short answer is no.
No, because then it will not allow her to ovulate, right? Now the next question is about GnRH by Dr. Veena. How long GnRH analogs can be given for endometriosis?
Okay. Again, it pretty much depends on what you're using it for. If it's for chronic pelvic pain, then we normally give it for 3 months first, keeping in mind that we may need to give another dose for 3 months, because 6 months is supposed to be having the maximum efficacy for the prevention of recurrence, not for symptom relief, but for the prevention of recurrence. If, however, you are worried and you want to give it longer, then beyond 6 months, always do an add-back therapy. So you can use it for 9 months to a year, but if you are going to use it for beyond 6 months, always do an add-back therapy with a low dose of estrogen, 2 milligrams or 4 milligrams a day.
Dr. Rahul Verma likes to know what is the management of chocolate cyst. I think you already mentioned it, but if you can just put in 2 lines on this.
So it depends on the size of the chocolate cyst and the symptoms. If there are no symptoms and if it is a chocolate cyst less than 7 centimeters, just leave it alone. If it is more than 8 centimeters and has symptoms, then you will probably need to operate. You have to still try medical therapy to alleviate the pain. And we are talking about adolescents here. I'm not talking about infertility or patients in later adult life. But in adolescents, you should still try medical therapy. And if there is no pain relief and the pain is significant enough to affect her quality of life, then only will you consider medical treatment. I can tell you from experience that you will find it extraordinarily rare to operate on a chocolate cyst or an endometrioma for an adolescent. I must have done maybe very, very few. I don't remember how many, but extraordinarily rare to operate on these cases.
Okay, Dr. Karthik wants to know whether there is anything that we can do to prevent endometriosis.
Again, short answer, no.
Okay, now this question is actually out of our scope of our program. But Sandhya, one person wants to know, do we use PPE in OPD? PPE in OPD.
Sandhya, you're muted.
Okay, fine. So, yes, we do use at least level 2 PPE. In that sense, what do? We use, we wear an N95 mask and we wear a gown and we wear a cap. And if you can possibly have your shield, face shield, then you should have a face shield. And you need to wear double gloves if you're examining a patient. I don't think you need to wear the footwear. So that's it. The cap, the mask, the face shield, double gloves. And after every patient, what we do is we also change the sheet. If you're examining a patient, please change the sheet. I go to the extent if I'm using a stethoscope, I also clean it with sterilium before I see the next patient. And I clean my own pen and my mobile before I leave the OPD.
This question is put by Dr. Meenal Mehta. Dr. Meenal, please understand that PPE stands for personal protection equipment. It does not mean the white dress. A green gown worn in an OPD is also labeled as a PPE, because the question she mentioned is PPE necessary in OPD or a surgical gown is enough? Now, a surgical gown worn in an OPD is PPE enough. Okay, Jaideep, the last 2 questions about one is from Dr. Reena, medical management of adenomyosis and endometrioma and its effectivity.
I'm sorry.
Medical management for adenomyosis and endometrioma and its effectivity. And the last question is from Dr. Geeta. How to manage infertility in patients of endometriosis? Now, that is a very big question to answer. But I think this you can take medical management of adenomyosis and endometriomas, and how effective are they?
First of all, endometriomas cannot be treated medically. Let's be very clear about that. Nothing which you give, I mean, there are some studies which show that Dynogest shrinks the size of an endometrioma, but it never gets rid of the endometrioma completely. So you would want to treat the symptom of the patient, whether it is adenomyosis or it's endometriosis or endometrioma. So if this is a patient who's got adenomyosis or endometrioma and has pain, then you do a run through that entire gamut of treatment which we talked about: NSAIDs, OC pills, or progestins, Dynogest, and GnRH. If she is presenting with infertility, then that's a different issue altogether, because then you have to balance between your treatment of pain and treatment of infertility. And it's not always an easy balance. Having said that, I would always prioritize the treatment of pain over infertility. Because if she doesn't get relief from pain, then she's not going to be very compliant with your infertility treatment. Medical treatments, if you follow this kind of a algorithm, are extraordinarily effective for pain management. I would consider doing surgery for patients only after all these treatments had relief. So that answers your question. And this is in effect with both adenomyosis and endometriomas. I do not remember the last time I operated on an adenomyoma. And we see a whole lot of patients with adenomyosis. So the only operation I recommend for adenomyosis is a hysterectomy. But of course, that's not an option when you're looking at young patients or patients who are looking for treatment from infertility. So Priya, if I may, for the second question, if you can give me a couple of minutes, I'll just give you a rule of thumb for that. And the rule of thumb is like this, that if you find at laparoscopy grade 1, grade 2 endometriosis, always treat it surgically. Never leave it. Don't do ovulation suppression for these patients. Treat it surgically. The preferred treatment is ablation, not stripping and not excision. Ablation. And you should ablate with an electric source. You may do it with a laser, but that's simply not cost effective. Once you have done that, wait for 3 to 6 months for the patient to conceive on her own if there are no other factors. And if the patient doesn't conceive, 4 to 6 cycles of IUI followed by IVF. It's actually quite simple. If you are looking at a patient of grade 3, grade 4 endometriosis, surgical treatment followed by 3 months of suppression followed by IVF. Very simple. You're muted, Supriya. You're muted, Supriya.
Very fantastically said, Jaideep. I think that is, the long of the short or short of the long, whatever ways. But I think you did it very well. So now I guess we are at the end of this session, and I'd like to propose a vote of thanks. First and foremost, thanks to our AMOX president, Dr. Nandita Palshetkar, for allowing me to bring up this, lovely session under the aegis of the Adolescent Health Committee of AMOX. A big thank you to my esteemed faculty, Dr. Jaideep Tang, Dr. Sandhya Saran, Dr. Girish Mane, Dr. Surekha Taide, and Dr. Rohan Palshetkar. It's a pity he could not join us for a very long time. I must thank Bharat Serum for being the partners in this endeavor for us, and the team of Science Integra, Mr. Seshan, Miss Sana. They've been working very hard. A big thank you to the entire audience, 400 odd people who are watching. When we see these kind of figures, it gives us more impetus to keep working, keep bringing up new topics. And let's sign off with a promise that we'll bring more such good sessions, not only in adolescent health but in various fields. Thank you so much, Jaideep and Sandhya. You've been here till the end, and in spite of all your emergencies, you all have come and put this program together. So let me wind up again with a poem. You remember Rapunzel at the beginning of the procession was suffering from PCOS and she was asking her beau to find another maid. So now the gynecologist or her obstetrician, gynecologist doctor has the last word. Ki Rapunzel, Rapunzel, get up and lose some weight. Eat less, run more, get laser for the face. Metformin, myoinositol, the list is going fine. COCs will help to get those hormones in line. So Rapunzel, let your spirit run free and wild. With us gynecologist on your back, you'll definitely get a child. Thank you, my dear panelists. Thank you, dear audience. And thank you, Bharat Serum. Thank you, Session and team. And I guess now we can sign off. Is Anuja or somebody there who can help us sign out of this meeting? So
Thank you
That's okay,
so
you can
much.
just- Thank you, Supriya. Thank you, Sandhya.
Thank you.